Yes, my people, it's another splendid day here on the magnificent continent of Africa, especially the beautiful country of Kenya. And I extend a warm welcome to all esteemed viewers of my esteemed channel, Etnandi Empress. Today we shall delve into an intriguing topic, the management of drug-susceptible tuberculosis. First, let us understand the nature of tuberculosis. Tuberculosis, commonly referred to as TB, is a chronic infectious disease that spreads through the air. It is caused by the notorious Mycobacterium tuberculosis. While its primary target is the lungs, TB can infect various parts of the body, such as the kidneys, spine, and brain. It is imperative to note that this infectious ailment, if left untreated or mismanaged, can prove to be fatal. Now let us shed light upon some vital aspects of management. One, importance of chest X-ray in TB screening and diagnosis. What are the importance of X-ray in screening and diagnosis? Look here, the utilization of chest X-ray plays a pivotal role in the initial screening and subsequent diagnosis of tuberculosis. This diagnostic technique aids in the identification of potential TB cases, enabling timely intervention treatment. Yes, my people. The second one is introduction of novel diagnostic techniques. Recent advancements in the field of TB diagnosis have led to the introduction of innovative techniques. Notably, for example, the Gene Expert Ultra, TB-LAM, and TB-LAM. These cutting-edge methodologies empower healthcare professionals to detect and analyze TB with enhanced accuracy and expediency. Yes, revision of TB diagnosis algorithm. An assiduous revision of TB diagnosis algorithm has transpired incorporating comprehensive guidelines to TB screening. Moreover, it provides informed insights regarding the interpretation of test results and appropriate follow-up procedures for the individual afflicted with tuberculosis. Yes, weight-based dosage of anti-TB medicine. The dosing of anti-TB medicine has been improved to accommodate the weight variation among individuals. Specifically, individuals weighing over 70 kilograms now have benefit of tailored dosing, ensuring optimal therapeutic outcome. Treatment approach for drug-susceptible tuberculosis in Kenya. In the remarkable country of Kenya, drug-susceptible tuberculosis is thoroughly managed through the utilization of fixed-dose combination. This comprises of 4 medicines. And this approach is meticulously designed to effectively compact cure drug-susceptible TB cases within the Kenyan population. Furthermore, it is crucial to comprehend the classification of tuberculosis. TB case finding. is a presumptive TB case? Biologically confirmed TB case. This classification pertains to individuals from whom a biological specimen has tested positive through smear microscopy, culture, or approved rapid diagnostic methods such as GeneXpert, irrespective of whether TB treatment has been commenced. All such cases must be duly notified. Yes, they should be duly notified. Clinically diagnosed TB case. Finally, we encounter individuals who have been critically diagnosed with tuberculosis based on comprehensive evaluation, including a careful examination of their medical history, symptoms, and potential risk factors. It includes cases diagnosed on X-ray abnormalities or suggestive histology and extrapulmonary cases without laboratory confirmation. Clinically diagnosed cases subsequently found to be bacteriologically positive before and after starting treatment should be reclassified as bacteriologically confirmed. All such cases should be notified regardless of whether TB treatment was started or not. Yes, you get that. All bacteriologically confirmed or clinically diagnosed cases of TB are also classified according to the following. 1. Anatomical site of the disease. 2. History of previous treatment. 3. HIV status. 4. Drug resistance. Based on anatomical sites include pulmonary TB and extrapulmonary tuberculosis. Pulmonary TB is any bacteriologically confirmed or clinically diagnosed case of TB involving the lungs, parenchyma, or the tracheobronchial tree. This includes pleural. Pulmonary TB is any bacteriologically confirmed or clinically diagnosed case of TB involving organs other than the lung parenchyma, e.g. pleura, lymph nodes, abdomen, genitourinary tract, skin, joints, bones, meninges, and many others. Classification based on history of previous TB treatment. That is the registration group. Classification based on history of previous TB treatment. That is the patient registration group. Number 1, new patient. This is a patient who has never been treated for TB or has taken anti-TB drugs for less than 1 month. Previously treated is a patient who has received 1 month or more of anti-TB drugs in the past. They are further classified by the outcome on their most recent course of treatment as follows. Relapse patient. Previously treated for TB, then declared cured or treatment completed at the end of the most recent course of treatment and are now diagnosed with recurrent episodes of TB. This could be either true relapse or a new episode of TB caused by reinfection. Treatment after failure patients. These patients were previously treated for TB and whose treatment failed at the end of their most recent course of treatment. Treatment after loss to follow-up. These patients were previously treated for TB and declared loss to follow-up at the end of their most recent course of treatment. These were previously known as return after default. Yes, you remember that term. Then again, we have patients with a known previous TB treatment history. This one should be managed as previously treated patients. Yes. Let's look at the classification based on HIV status. We have HIV positive patient. I think that is self-explanatory. HIV negative TB patient, and then HIV status unknown TB patient. We can also come to the classification based on drug resistance. One of it is drug susceptible TB. This one is any bacteriologically confirmed case of TB with no evidence of resistance to any of the first-line anti-TB medicine. And then the second one is drug-resistant tuberculosis. Any bacteriologically confirmed case of TB with confirmed resistance to any of the first-line medicines. It also includes cases with confirmed resistance to second-line anti-TB medicine. Yes. Diagnosis of tuberculosis. Active TB case finding is key in diagnosis of TB in adults and adolescents. This involves screening of all persons visiting the health facility using key screening questions, which include presence of cough of any duration, hotness of the body, temperature over 37.5 degrees, drenching night sweats, unintended weight loss, BMI less than 18.5, chest pain. Persons who screen positive for any of the signs and symptoms mentioned should undergo thorough clinical evaluation before classification as presumptive TB case. Presumptive TB cases should undergo diagnostic classification as per the TB screening and diagnostic algorithm for adults and adolescents over 10 years of age. To make a diagnosis of TB disease, we should follow the following steps. Number 1, history-taking TB diagnosis starts with taking thorough medical history. TB should be ruled out in any person presenting with the signs and symptoms of TB. History of contact with a TB patient, and then the main aim of history taking is to rule out other differential diagnoses of TB disease. For example, COPD, heart failure, bronchiectasis, lymphoma, lung cancer, sarcoidosis, fungal pneumonia. I think we know some of these fungal pneumonias. These fungal pneumonias include aspergillosis and histoplasma. Step 2, you do physical examination. In physical examination, you look at the signs of TB on respiratory examination, which may include tachypnea, bronchial breath, dullness on percussion, and then reduced air entry, fever over 37.5 degrees, wasting, hemoptysis, and even pallor. If the patient does not have any of the signs and symptoms as we mentioned and not found to be presumptive TB case, on further clinical review, evaluation should be done. Evaluate the patient for TB preventive therapy. And then in step 3, investigation for diagnosis of PTB. GeneXpert is the preferred first test of choice for PTB diagnosis and detection of rifampicin resistance. All persons with presumptive TB should undergo microbiological testing to confirm the diagnosis. Yes. Key considerations in the choice of TB diagnosis test to be used include the following. When gene expert testing is available on the site, a sputum sample should be collected and sent for gene expert testing. When only smear microscopy is available on site, 2 sputum samples should be collected. One for smear microscopy and the other one for gene expert. And these should be transported to the nearest gene expert facility. If smear microscopy is positive, the patient should be started on drug susceptible treatment and reviewed once gene expert results are received. A negative smear microscopy results does not rule out TB. If both gene expert and smear microscopy are not available on site, a sputum sample should be referred to the nearest gene expert testing laboratory. Yeah, sure. Let's talk about TB LAM. LAM. This should be considered for eligible people living with HIV as per the diagnostic algorithm. If positive, initiate drug-sensitive tuberculosis treatment and review once gene expert results are received. A negative TB LAM results does not rule out tuberculosis. All adult patients newly diagnosed with TB should undergo HIV testing as per the HTS algorithm and diabetes testing as per the Kenya Diabetes Guideline. Oh, let's look at the tuberculosis investigation. Number 1, Gene Expert and Gene Expert Ultra is preferred test for choice for all presumptive TB cases. It is actually used for diagnosis of TB and detection of rifampicin-resistant tuberculosis. For smear microscopy, all presumptive pulmonary TB where gene expert is not available, it should be used. Let's talk about smear microscopy. It's used in all presumptive pulmonary TB where gene expert is not available. Huku mashinani. It's also used in all DSTB patients for treatment follow-up. So microscopy is so useful. It's also used to detect TB disease, monitor of bacteriologically confirmed TB patients on treatment at month 2, 3, 5, and 6. Yes? Let's look at chest X-ray. Chest X-ray is normally preferred for all presumptive pulmonary and some extrapulmonary TB, where excessive and affordable. It is a screening tool to identify those at high risk of TB disease. It also supports TB diagnostic, especially in children and when sputum for AFB or gene expert is negative or not applicable. Yeah? Let's look at histology. It's used in all presumptive extrapulmonary TB tissue diagnoses if it's actually suspected. For example, in TB adenitis. Other supportive tests include tuberculin tests and even IGRA. Tuberculin skin test and IGRA is used for detection of TB infection. Also used in detection of latent TB infection. LFLAM or lateral flow urine lipoaramino Aman assay is used on HIV infected patients with severe illness or advanced disease. All hospitalized people living with HIV, and it's used for diagnosis of TB as an add-on test or Gene Expert and Gene Expert Ultra. It is an add-on test to gene expert testing to increase diagnostic yield of TB testing in severely immunocompromised people living with HIV. I have a few things that I need us to note. 1. All the attempts must be made to make a bacteriological diagnosis of PTB in adults. Sure. I want to make a conclusion. It is crucial for us to comprehend the necessary knowledge and protocol surrounding the management of drug-susceptible tuberculosis. Equipped with this understanding, we can collectively combat this debilitating disease and strive towards the healthier society. Thank you for joining me on this enlightening journey. Until next time, take care and continue prioritizing your well-being. This is Ethnandi Empress.